محتاجين نبقى واخدين بالنا.
من القمم اللي موجوده في مصر. هنبدا باستاذنا الدكتور بهاء قرنة Professor of Orthopedic Surgery الازهر University. We speak about.
يعني it is very I am pleased to be with you and all BANHA professors and colleagues for this very nice, interesting course for orthopedic and subspecialties also. My talk about the cervical spine and also dorsolumbar and the lumbar spine. The problem is about 12,000 new spinal cord injury every year. لكن في من about from 3 to 25% of the patient with cervical spine injury suffering extension of this injury from the delayed in diagnosis or unwarranted manipulation of in the ER. The solution for that is a systemic approach that identifies the spinal injury and appropriate care of the spinal unit in such injury and instability is ruled out. This is some anatomical landmark about C1 atlas. It is very important that there is no body with two articular pillars with two arches in anterior and posterior. Where C2 anatomy, it is dense. It is embryologically from C1 body, where flat C1 two joint, vertical and vertebral artery foramen in both sides. The bony landmark, other distal part from C3 to C7, it is similar to each other. And we have to know about AtlantoAxial indentation. The tactile membrane is an extension of the posterior longitudinal ligament. And this is some anatomical landmark about transverse ligament, which is very important for stability of C1 and C2 and the other joint. And this is AtlantoAxial anatomy and the transverse ligament, which is responsible for stability of the C1, C2 and the pre-dental space anterior to the adenoid. And this is the vertebral arc from the posterior, the junction between C1 and C2. And this is a basic ER management. It's very important and when to obtain the X-ray. This is steps component is very important. You know about the injury and the listen and touch the thing and obtain the imaging and interpreting and study this and the correct diagnosis. If you don't follow this systemic approach, missing one step, you fail to diagnose. So the evaluation of the cervical spine is starting by history, physical examination. The bony fracture demonstrated on the X-ray or CT, but the ligament injury expected from the X-ray by the presence of an abnormal angulation, translation, separation, or soft tissue swelling. The common mechanism of injury for cervical spine, it is a hyperflexion or hyperextension or compression injuries. When obtain the X-ray and CT or MRI, this is the high risk factor for the spine injuries, low high velocity blunt trauma, multiple or severe long bone fracture, direct cervical regional injury, and alternating in the mental status failure from the greater than 10 feet and another example. The modalities available in the radiology, plain X-ray, it is very important and you can diagnose a lot of things. Fluoroscopic, ultrasonography, CT, MRI, and nuclear medicine and angiography. So it is your responsibility to study this film carefully to either diagnosis and excluding the injury. This is doctors who are responsible for that. So the spine can be divided into cervical spine injury or thoracic lumbar spine injury. This is the approach to reading the X-ray, know what the normal anatomy look like. This is very important to know the normal anatomy. Always take a systemic approach, as we mentioned before, starting by soft tissue or bony or soft tissue, and we'll speak about later. A little distance can be a good thing. يعني دايما go away a little bit from the X-ray, so from it you can sometimes identify something which you can missing you. But then experience counting, this is depend on your, the more you see, the more you learn. The lateral view film, it is very important. It's a film classified when you have the X-ray. nothing obscured by jewelry or other opaque object. Penetration okay, layer resolution, and adequate film. And always think about these people who is syndrome for relative of the patient. Normal plane film evaluation is very important. This is the standard radiography for the cervical spine, AB lateral and odontoid views and oblique views. But the optional views is the swimmer and deflection and extension film to evaluate the instability. This is what we call the three pigs. What it means, the three pigs, the cervical spine films must be lateral, anteroposterior, odontoid, open mouth view. But some centers in the trauma center, they think that supine chest film is sometimes the trauma team routinely including lateral lumbosacral spine film to make the big four. This is a spinal film and how to read it. Counting the vertebra is very important. Assess the curvature, very important. Assess the vertebral alignment, very important. 4 lines. Assess the bony integrity. Assess the intervertebral disc space. Assess the joint and soft tissues. But this is a very big. So we concise this into ABCs. ABC, when you look for the film, look for A, alignment, B, bony abnormality, C, cartilage space, and S, the soft tissues. You have to remember this, and when you read the X-ray, put this in your mind, and you will not missing anything. So for the normal odontoid, this is a normal odontoid view, what we call mouse view. You will see the this is what we call odontoid view. You will see the odontoid process of the C2. This is landmark by red. Then you will see the red color. This is the lateral mass. This you can identify the bony landmark. And when you're looking for this, look for the lateral mass alignment. It has to be similar in each other, and the integrity of the dens. Look for the integrity of the dens. From this view, so you are looking for the lateral mass alignment, if there is a mismatching or displacement, and the integrity of the dens, there is a fracture or not. This is the normal X-ray of the transoral views, what we call the odontoid views. The distance between the odontoid and the lateral mass A and B, it is equal, and the normal relation between the lateral mass and the body of the C2, it is equal as the similar, and it's better to each other. Lateral view, there is what we call pre-dental space, and when you do an X-ray, you have to see from the C7 T1 to the base of the skull. Otherwise, this is inadequate film. Look for this film. This is it adequate or inadequate X-ray? There is obstacles by the nameplate in the upper part of the X-ray. Also, the occiput and the platelet not seen, and at least the top edge of the T1 should be seen. So this film, it is not, it is inadequate film for diagnosis of this patient. So this is adequate film in lateral view. The 80% of the injury found in these views. Adequate film must see the occiput to the T1, needed to be able to see soft tissue shadow, swimmer views, or CT if unable to see the T1. And this is the interpretations of the X-ray of the lateral view. And this is the lateral mass. Here, this is the lateral mass. Here is the joint line, double or cortical line, which is the facet joint. This is the lamina here. This is the space. This is the lamina. And this is the pedicle. It is a small part. This is the blue one. And the spinous process, which is the C7. So how to interpret it? This is the bony landmark of the lateral view. And this is the junction of C1, C2, and how to read it. And here, this is the pre-odontoid space, the anterior part of the C1. And this is the odontoid process. And this is the space, and this is the cortical bone ring of the C2. This is example of pre-dental spaces, what we call the anterior atlanto-dense interval. This is dense, the odontoid process of the C2. This is C1 body, C1 arch, and this is the space between the C1 pre-dental space or anterior, what we call anterior atlanto-dense interval. It is normally about 3 millimeters in adult. In children, it can be up to 5 millimeters. But if there is more than 3.5 millimeters, this means that there is injury to the transverse ligament. And if it is more than 5 millimeters, there is rupture or instability due to rupture of the transverse vertebral ligament. And there is some radiological diagnostic screening lines. You have to know about what we call Harris lines. Based on that, this is and this is vertical line. The relation between this line and this line, it is always less than what we call the 12 millimeter in 95%. Less than 12 millimeter mean more than abnormality. The patient axial interval, patient axial interpretation to the posterior dense, there is what we call the abnormality subluxation or anterior subluxation or posterior subluxation according to the distance more than 12 or less than 4 millimeters. This is a power ratio, which is PC to OA, and this is always normally about 1 to 1. If it is, but it is now limited useful, positive only in anterior translation injury and the false negative with pure distraction. This is called power ratios. This is the landmark of the C2 cervical spine and how to read. This is the disc space, and this is the soft tissue space, retropharyngeal and retrotracheal space here. And this is green one. This is a disc space. And we have to know the 4 contouring lines. This is 4 lines, very important, representing the anterior vertebral line, posterior vertebral line, and the spinolaminar line, and what we call the posterior spinal line. It can be reduced into 3 lines, but this is the 4 line. This is the 3 line, can be. Don't forget, we are speaking about the alignment, which A, B, C, S. The following the continuing of the 4 line. Any disturbance means there is an abnormal in the alignment. And don't forget about the pre-dental space, as we mentioned, in adults 3 millimeters, in children 5 millimeters. This is the lateral view. You can see from C7, from C71 up to the odontoid process and C1. This is 2 lines presenting on the X-ray. You can see the 3 line, which represents the normal alignment of the cervical spine. What about curvature to follow? This is the 3 lines we mentioned before, and this is abnormality or not. You can see there is normal contouring of the anterior longitudinal and anterior body, representing the anterior body, the posterior, and the spinolaminar lines. Abnormality in the curvature, the malalignment of the posterior vertebral body, it is more significant than the anterior, because the anterior, there is sometimes you have osteophyte, but in the posterior, you rarely find a big osteophyte. The spinal canal diameter is significant, narrowing if less than 14 millimeters. Anterior subluxation causes by facet dislocation. It can be if it's represents the body more less than 50%, up to 50%, means that the width is unilateral facet dislocation. If more than 50% of vertebral body width, this means that there is a bilateral facet dislocation. Widening of interspinous space is very important, representing the interspinous ligament disruption. This is the cartilage space and the soft tissues we mentioned about the cartilage space and the soft tissues. This is a cervical measurement. If there is a displacement like more than 3 millimeters, this means that there is subluxation of the vertebra. And if this two line more than abnormal angle more than 11, this means there is an abnormal facet or subluxation or representing instability of the cervical spine. This is the abnormal angulation more than 11 degrees than the contiguous segment. This means disruption of the posterior longitudinal ligament or subluxation of the C3 or C4. This is representing the X-ray. What about the lower cervical detection? We are looking for the spinous process gap, any gap between the two spinous process, the facet joint position, well, as we see in the normal X-ray, intervertebral gap, any intervertebral gap, angulation, and translation. We will go for this point one by one. What about the interspinous gap? This is, you can see there is a gap between the two spinous process, means there is something or ligamentous injury in this part. If the facet joint position, if it is not parallel to each other, there's that this is the two lines. If there is an abnormality, this means that there is an facet subluxation. What about intervertebral gap? If there is abnormality in the intervertebral gap, the measurement means that there is element of injuries or instability. Angulation more than the posterior wall or the posterior longitudinal ligament pathway. If there is a difference in the angulation, which means that it's supposed to be zero, this means that there is an element of subluxation. What about the translation? This is the amount of more than 3 millimeters means there is abnormal translation of the vertebra. This is an example of abnormal soft tissues, and we are speaking about the alignment. Now we are speaking about the soft tissues. The soft tissue representing the space between the trachea and pretracheal fascia. This is the normal retropharyngeal space in the C2, and in the distal part is the retrotracheal space. I have something you can say that 2662. 26 means that as the C2, there's about 6 millimeters. As the C6 down 2 centimeters. This is be simple equation. You can remember it in the future. 2 6 6 2. 2 means that as the C2, it's about 6 millimeters. 2 6 6 as the vertebra 6 means that 2 centimeters. Any difference between these can be means that there is a space occupying lesion, as a retropharyngeal hematoma, retrotracheal space or injuries. There is a swelling. An abnormal measurement may indicate a soft tissue swelling from obvious or occult fracture like hematoma or presence of abscess. This is an example of retrotracheal swelling, as we mentioned. 2 6 6 2 يبقى مين هنا أكتر من 2 سنتيمتر means that there is a space occupying lesions. This is the C2 and C4 and C6. What about the AB? In the AB, you are looking for, as we mentioned, the alignment. So we will looking for the interspinous, the spinous process, which is supposed to be in the same line. Any difference in the spinous process means that there is an element of rotational or element of subluxation. This is an example. This is a plain X-ray of the spine, and this is the 3 lines, lateral border and the spinous process line. It must be in the same line. Any deviation, medial or lateral, means there is subluxation or dislocations. What about the normal oblique? What means this round one? This round one representing the pedicle of the other body, pedicle of the other part. What about this line? Representing what? This is the lamina of the ipsilateral, and this is the body, the vertebral body, and this is the intervertebral foramen. So how to read the X-rays is very important to know the normal oblique views. What about the lines? The inferior articular facet to superior articular facet, it must be parallel to each other and make a normal angle and parallel to each other for the upper vertebra and the lower vertebra. But if it is disruption, means that there is something wrong, means that there is a facet dislocation. And this is an example of the normal alignment. The 50% subluxation indicated unilateral facet dislocation or fracture about 70 to 80%. This herniation, it occurs for this facet by about 10 to 40%, and may compress the spinal cord. So in the patient like this patient, there is bulge of the disc space, and you want to try to reducing by traction. This may be compromising the cord. So for this patient, you have to go from anterior first to remove the disc material, then go back, reduce the facet dislocation, and then go for anterior for fixation. Well, this is the example of unilateral facet dislocation of the example, and you can see from the CT and and also notice that the C7 there is a fracture also. So this patient has a double mode of actions, double mode of fractures. And this is a facet dislocation mechanism. It can always come by flexion with a rotation, and the flexion with extension can be leading to dislocation or facet dislocation. If the patient like a short neck or has a difficulty to see the C7 and T1, you do what we call the swimmer view, and this is the interpretation of the nerve. This is an example. This is the clavicle, and this is the other clavicle, and you can see the C7 and C7 and T1 on this swimmer view. It's very important because this is the transitional zone between mobile segment and non-mobile segment. Or this is an example and interpretation of the swimmer views. So the flexion extension film, do we need to do an flexion extension film for every patient? Excluding this film always needed to exclusion the ligament injury in minor malalignment routine film. لو انت عملت malalignment ولقيت malalignment, you can do flexion extension film. Severe or persistent neck pain or spinal tenderness and with the normal plane film. لو العيان جالك بعد فتره وانت لقيت برضه لسه في persistent و severe neck pain, you have to do an flexion extension film by yourself. Lateral view obtaining during flexion and extension, don't move the neck beyond the painful position. دايما guarded يعني تروح مع with your patient and do the flexion extension film under your supervision. And always do it if there is a persistent neck discomfort, and repeat the flexion extension film in 1 week. And MRI also may be useful to detect any ligamentous injuries. And this is some example of the fractures, which is a common Jefferson fracture with the fracture of the C1, and it has many classification. And you can see only in the transoral views or mouse views. This is Odontoid, and this is the space displacement, and also the relation between the body and the lateral mass is disrupted, means that there is a Jefferson fracture. And this is the classification of Jefferson fracture going from type 1 to type 4. What about hangman fracture, which is a traumatic spondylolisthesis, and they occur in the body of the C1 or called the hangman fractures. It is occur between the traumatic spondylolisthesis. Dense fracture, which is a fracture of the odontoid process, and it has 3 types, and also you can see by the lateral view and also in the transoral views. And this is an example of the dense fracture at the base. Compression fracture, which is injury due to diving, example, or overload on the head. and it is variable, severe from minimum anterior wedging to the complete disruption of the vertebral body, and this is an example. Also, this is a very important injury which is affecting the inferior part of the body. It is called teardrop fracture. It is a avulsion fracture of the anterior margin of the vertebral body, the anterior longitudinal ligament instability, and this is rupture or avulsion and a very unstable injury, and it can lead to serious complications. What about Clower-Shevard disease? This is a patient اللي هم بيضربوا بالسطور او بالمنجله على ظهره فبيجي له شيفر فراكشر، وده بيبقى دايما fracture of the C7 spinous process. عشان كده لو ما كنتش if you cannot see the C7, you can missing this type of fractures. So the indication if you do a plain X-ray and you are not happy about it, and you're going for other modalities, the CT and the cervical spine, if you have inadequate plain film survey or suspicious of plain film finding or fracture and displacement demonstrated by standard radiography or high clinical suspicious of injury despite normal plain film survey. What about the magnetic resonance? You can do an obtaining the MRI for any neurological deficit. أي عيان عنده neurological deficit you have to do an MRI عشان تقدر تشوف إن في acute cord hemorrhage ده تعتبر منه poor prognosis أو cord edema or contusion may be significant improve أو mixed cord injury أو evaluated non-osseous structure. لو ما عندكش bony injuries وأنت مش عارف زي ligamentous زي acute disc herniation أو ligamentous injury أو cord compression أو cord edema أو cord hemorrhage أو epidural أو subepidural hemorrhage أو vertebral artery occlusion, you can do MRI. This is an example, and I think the next lectures will be delivered for this MRI. We are looking forward to hear about it. This is an example to do disc. What about thoracolumbar spine injury? It is very important, and you are missing a lot of injuries, and this is one of the complications. So know the anatomy. Look for the stability and stable spine. Basic trauma factors are very important. Fracture pattern is very important. Post-operative evaluation is very important. So determine the stability of the dorsolumbar spine. It is very important. The more stable than cervical spine. ليه lumbar dorsal spine stable؟ عشان فيها strong ligament, فيها stabilization by the ribs, very important. Bigger intervertebral disc, large facet joint, and it is mobile. Fracture and dislocation tend to occur where is the curvature change. دايما الفراكشر بيحصل فين؟ في الترانزيشنال زون اللي between fixed و non fixed part. دايما في زي ما في T1 من T12 to T11 to 12 اللي هو thoracolumbar junction او L5S1 lumbosacral junctions. Stable or unstable is very important to put it in your mind. The radiological findings suggest of instability like the vertebral body collapsed, the widening of the pedicle, لو أكثر من 33% of the canal compromising on the CT, أو 2.5 millimeter constellation between the vertebral body and the anterior plane, or bilateral facet dislocation, or abnormal widening between the spinous process or lamina, and 50% anterior collapse of the vertebral body. الميكانيزم اوف انجري لازم نعرفهم اللي هم هايبر فليكشن وشيرنج وهايبر اكستنشن واكزيال لود. ده استابيليتي اللي هي تشيك ليست اللي هي بتدي 2 بوينت او 1 بوينت. الانتيريور اليمنت ديسربشن 2 بوينت، posterior element disruption, sagittal translation, sagittal brain rotation, spinal cord او disruption في الcostovertebral articulation او dangerous. لو more than 5 or more patient is unstable until heal or surgically stabilized. والحاجات المهمه قوي stable بتاع لو risk of neurological injury دايما الريسك بيحصل عند حتتين مهمين قوي اللي هو diameter تبقى decrease في الdiameter of the spinal canal اللي هي لو 35% canal narrowing at 12 at thoracic 12 and 11 and 12, 45% canal narrowing at L1 و 55% of the canal narrowing at L2 and below. الابروتش تو السباين برضه قلنا عليهم الاي بي سي اللي احنا قلناها قبل كده. adequate alignment، بص adequacy and alignment of the vertebra، look to the bone and look for the cartilage and look for the soft tissues. ده الانتروبوستيريور سباين and the lateral view of the dorsal spine. ده الاكس رايز اللي هي نورمال، هنشوفها نقدر نعمل عليها ترجمه للاكس راي و translating this. This is the normal alignment اللي هو الانتيريور والبوستيريور والانترفيرتبرال ديسك سبيس. ده النورمال اي بي اند lateral. ده كلوز اب فيوز، ده السبيس اللي هي هنشوف اللي هي نورمال الاينمنت ونعرف منها الهايت والبتاع. دايما الانتيريور بودي الانتيريور بوردر اكبر من البوستيريور بوردر about 2 ملم، عشان كده بيدينا الكيرفيتشر اللي هي الكايفوتيك كيرفيتشر بتاعت اللي هي دورسال سباين. ده الاي بي بتاعت اللامبو سوري الدورسال سباين. هاو تو انتربريتد اللي هي نعرف فين البيديكل، نعرف السباينس بروسيس، نعرف الكوستو فيرتبرال انجل اللي هنشوفها بالطريقه دي. ده الموجود، ده الفيرتبرال بودي اللي احنا بنشوفها اللي هو البيديكل الموجوده. ده السباينس بروسيس اللي هي البلو 1. البلو 1 دي الفيرتبرال بودي، الفيرتبرال بودي البلو 1. اليلو 1 it is the spinous process. ده transverse process of the dorsal spine اللي هي between the two vertebrae. ده الانترفيرتبرال او الديسك اللي هو الانترفيرتبرال جوينت اللي موجوده، ودي relation between the transverse process and vertebra and ribs. Very important to know the distance, is the configuration, and to exclude any other trauma. نشوف ده normal lumbar spine. ده normal alignment between the disc space والexit from زي ما احنا شايفينها. It is very clear to take a dead lateral view. How to read it? This is the plain lumbar spine. This is the body. This is the intervertebral disc. This is a facet joint. This is a varus interarticularis, responsible for spondylolysis. The inferior articular process, and this is the facet joint, and this is the disc space of the vertebral body. And this is normal. This is a close-up view. The varus interarticularis is very important because we're asking a lot of people who don't know. And this is the spinous process of the lumbar vertebra. And this is very important for the people who is working on the spine for the pedicular fixation. This is the suprapedicular space. This is the infrapedicular space. This is the pedicle, the width of the pedicle, and this is the disc space. And when you do an AP lateral, you do an oblique view representing the to represent in the cases of spondylolysis the varus interarticularis defect. This is what we call the Scotty dog oblique views, representing the superior facet, the ear of the dog. And this is the nose, and this is the neck, which is representing the varus interarticularis, if there is, and this is the leg of the Scotty dogs. And this is the normal AB, and where is the transverse process, where is the spinous process? This is the diagram representing the spinous process and the pedicle, and it's very important to know the anatomy of the pedicle when you go for spinal fixation. This is the close-up views, and this is the pedicle. This is the transverse process. Very important because many people has sometimes fracture of the transverse process alone. This is the lateral view of the lumbar spine, and this is the 3 columns theories of the fracture, which indicate stability or unstable. If 2 columns injured, means that this fracture is unstable. And it's very important to know the interspinous ligament and the space. And this is the 3 column. This is the anterior column from the anterior to the ligament to the 1/3 on the body. And this represents the middle column, and this is the posterior column. If you have 2 columns injured, means this is a fracture, it is unstable. This is an example of the 3-column injury. This is an example of spinous process injury here. This is an example of the anterior compression injury of the vertebral body here. And this is representing the burst fractures here. And this is shearing fracture of flexion, distraction fracture, chance type injuries. And this is representing the people who is working to do a spinal fixation and how to know the inclination of the Euro screws. This is the pedicle, the end of the pedicle between the transverse midline of the spinous process and the angle of the facet. This is the entry point for the spine, for the pedicle, for the screw to go fixation. This is the inclination, cephalic and caudal inclinations. About the caudal and the cephalic inclination of the body of the vertebra is different from L1 to L5. This is L5 inclination. This is an example of a compression injury of the lumbar L1, which is the transitional zone. There is loss of the height. This is the normal T12 and the normal height of L2. This is an example of the disturbance of the height of the same and there is a loss of the height indicated in the AB views. This is an example of a compression injury of L1. This is an example, disruption of the anterior column, loss of the height, and the disruption of the middle column. This indicated the severely unstable fractures. This is an example of compression injury of dorsal 12. And this is presenting the distance between the pedicle is very important. If disruption of the distance between the two pedicle means that there is a disruption or abnormality. The paraspinous hematoma representing here, and there is a rib fracture, and the distance of the pedicle. Suppose this is the pedicle, this is the normal, but here is there is widening of the pedicle, indicated the instability of the fracture. This is the distance between the two pedicle, as the same case, and representing that the pedicle means that there is a severely injured spine. This is an example of compression injuries of dorsal 12. This is shearing, and there is an increasing in the interspinous space. It's very important here, comparing this between the spinous process and this is interspinous space. This is an example of widening of the vertebra, increase for the interspinous distance, and the disruption of the pedicular fractures means that there is unstable fractures. This is an example of compression injuries, and there is a loss of the height and increasing for kyphotic, increase for alignment means that there is changing in the alignment, increasing that indicated that there is a kyphosis. This is a transverse process fracture. It's very important, maybe due to muscle action or the contraction or injuries, and it can be missing if you don't have a good adequate film. This is an interpretation of the transverse process fractures. This is an example of sharing a fracture of distraction injuries, and this is an injury which indicated instability. So remember, it is your responsibility to read the X-ray, to diagnose and to exclude the injury. In the summary, comparing with the level above and below, translation of the morphology and the height should be smooth. Remember the mechanism of injury, knowing pattern of injury can help with detection of stable supple fracture and secondary fracture, CT, any suspicious area. Take home message, be systematic, review with the history and the physical examination in mind. And في الآخر بقول لكم thank you. Be aware of the owner, not the dog. And this is افتكاسات المصريين عشان يوفر بس شوية. وأخيرا دي برضه افتكاسة من افتكاساتنا اير باج عشان يحمي نفسه طبعا. وفي الاخر بقول لكم ثانك يو، واشكر الدكتور اشرف على الدعوه الكريمه، والدكتور محمد طبعا على مجهوده العظيم. وطبعا كورس بنها ده مسمع في كل مكان، والحمد لله يعني ليه سمعه كبيره جدا. شكرا لكم جميعا.
Thank you so much, sir, for this very valuable talk, summarizing all the pathological conditions that we are facing in X-rays of the cervical or lumbar spine. معانا الدكتور أشرف بيه والدكتور ممدوح بيه for moderation. دكتور أشرف بيه والدكتور ممدوح، اتفضلوا يا فندم.
ألف شكر يا دكتور بهاء، وسعادتك نورتنا وشرفتنا في الكورس.
دكتور جلال بيه joining us now. دكتور جلال بيه منور يا فندم.
اهلا يا دكتور محمد.
ازيك يا استاذنا؟ ازي حضرتك؟ منور يا فندم. اتفضل يا باشا.
في عندنا في بعض الاسئله موجوده. How can we suspect whiplash injury from plain X-ray؟
قلنا اي حاجه فيها سوفت تيشوز بتعرفها من 3 حاجات: abnormal alignment، او فيها لو كلينيكال طبعا لو العيان جالك كذا مره وبيبقى سسبكتد البين فتضطر تعمل له الفليكشن اكستنشن فيلم او تعمل MRI لو عندك فاسيلتي. ما كانش كده في البلين اكس راي. لو جالك في اول مره اي abnormal alignment من الحاجات اللي هي او سوفت تيشوز او suspicious من التروما نفسها you have to be suspected، لان احنا قلنا من الحاجات اللي فيها ريسك فاكتور منها التايب اوف تروما، المود اوف تروما، الحاجات دي كلها من الحاجات اللي تخليك تبقى لو واحد راكب عربيه واتخبط وراسه حصل له هايبر اكستنشن لازم نبقى في عندي حاططها ان مايند، والا هبقى ميسنج الدايجنوز.
كان في سؤال تاني بيقول الآتي: is X-ray now is less important or not؟
لا، البلين اكس راي از فيري امبورتنت، لان احنا قلنا حتى في اللاترال فيو في السيرفايكال سباين بتدينا حوالي 85% من الانجري ممكن تقدر تعرفها من اللاترال جود لاترال فيو. وبعدين هي دي موداليتيز بتعرف منها حاجات كتير جدا، وتقدر ممكن تبقى ميسنج يعني حتى يعني طبعا لسه هيطلع الMRI اللي هو بيسموه دايناميك MRI، لكن الى الان الدايناميك اكس راي ما تقدرش تعملها الا عن طريق الريز. وفي نفس الوقت من الحاجات المهمه جدا بتساعدك في التشخيص، وفي نفس الوقت تبقى دوكيومنتري معاك.
شكرا يا دكتور بهاء، الف شكر.
دكتور جلال بيه سعادتك
I would like to actually أحب الأستاذ دكتور بهاء قرنة
الله يخليك دكتور جلال
في هذا الكورس، واحنا نشكره شكر جزيل يعني، واخ عزيز وغالي علينا.
الله يخليك دكتور جلال.
النقطة من ضمن النقط المهمة اللي أنا أحب أوضح بس حاجة صغيرة كده، إن flexion extension views is very important in case of cervical injuries، ودي لازم تبقى attended by the doctor not to be left by the nurse or to be sent تروح باعت العيان كده ومعارك وسط بيقول flexion extension views. This can be disastrous. فالدكتور should be attending and the patient should be flexing his head and extending his head within the limits of pain. I would like to point and stress again ان clinical examination في حالات التروما يختلف عن الكلينيكال اكزامينيشن في الحالات الايه الباك بين العادي او السباينال بين العادي. لازم نبقى كوشس وجنتل، والعيان بيبقى نايم على السرير we should feel his back for local tenderness and we should see if there is any step موجوده في الظهر او ما فيش، وبرضه بنشوف presence of hematoma or so. بس دي كومنت صغيره كده احب اقولها بس. شكرا يا بيه.
Thank you so much sir. شكرا دكتور جلال، استاذنا الكبير دكتور جلال بيه، ونشكر استاذنا الكبير الفاضل استاذ دكتور بهاء قرنة على تشريفه لنا والسبورت اللي هو عامله لنا في الكورس. حضرتك بصراحه كنت اكبر سبورت لنا في الكورس دكتور بهاء بيه، فاحنا نشكر وجود سعادتك معانا ونامل ان حضرتك ما تحرمناش برضو من التوكس الجميله بتاع حضرتك دي ان شاء الله.
لا تحت اي وقت يا دكتور.
شكرا جزيلا يا استاذنا. دلوقتي هننتقل